You know, there's a medicine that's been quietly changing the trajectory of some of the sickest babesiosis patients that I've ever treated. And unfortunately, I'm watching this get handled very casually. I'm hearing 400, 500, 600 milligrams a week being discussed as, just normal routine escalation of this medicine, when in fact, it's not. And if we don't slow this conversation down right now, we actually risk harming our patients and potentially losing access to one of the most powerful tools that we currently have. So the topic that we're talking about today, and what I'm about to say, needs to be said very clearly. Hey guys, I'm Dr. Tom Moorcroft, and I've been specializing in the treatment of Lyme disease, babesiosis, and other vector-borne illnesses for over 15 years. And not only that, I'm a former Lyme and babesiosis patient myself, untreated for 8 years. And after a long, disciplined healing journey, well, I've been symptom-free for over 13 years. So one of the things I want you to think about is how many people in the Lyme world can tell you that? How many doctors can say that they've treated people to being symptom-free, and how many patients are there? I've done it, and I've done it with hundreds, if not thousands of patients at this point in my career, and this is so important. And today, you may notice I'm dressed down a little bit and look like I just came in from my winter chores or possibly skiing. And that's because I did. And when I first came in, I saw a question in my Lyme disease practitioner certification and mentorship group just about this exact topic. And so I sat down, wrote a few notes, and really just turned the camera on. No production, just honest talk, because this is happening right now, and this is so important. Today, we're gonna be talking about Tafenoquine. Tafenoquine's not just another one of these anti-malarial drugs that we use, an antimicrobial, anti-parasitic. It's a really kind of an interesting drug. It's an 8-aminoquinoline medication, and its cousin was actually, brought out in the 50s, but it has to be dosed multiple times a day. Now we have this really interesting drug that was FDA approved in February 2018, and it's got this really long half-life, 14 to 16 days. It's an oxidative drug that has linear pharmacokinetics, and it accumulates in our tissues quite readily. So when you increase the dose, those levels will rise proportionately. And there's really no magic ceiling here. The more drug you take, the more exposure your patient has, and then guess what? More physiological stress. And that's pharmacology. Not my opinion, not someone else's opinion, hard scientific fact, how your body and your patient's bodies are working when they consume this medication. So why are we so excited about it? And what does the data really show about this medication, Tafenoquine? Well, in preclinical work by Dr. Ben-Mamoun's lab at Yale, they showed the ability to eradicate Babesia microti and Babesia duncani in mice at 10 milligrams per kilogram doses when combined with atovaquone. So in clinical practice, the standard human dosing as an antimalarial or as an anti-Babesia medication for acute infection is typically 200 milligrams per week. Now, think about this. With the linear pharmacology, that basically means if we were to go back to that mouse, we're looking at about 20 milligrams per kilogram for each dose. Our standard human dosing is already twice as high as what the eradication dose was in these mice. The important thing to remember is in this trial, they were looking at an acute babesiosis model. Many of the patients that I'm working with actually have chronic babesiosis, and there really are no trials, but we can use this information to really help us. Because if you look across the board in infectious disease research, there's almost no in vivo or in a mammal host that's an acceptable model for a human to compare any of these drugs to. We just do a study in a petri dish or a test tube and we say, hey, let's try it out in people. And Big Pharma does a lot of work to do all these studies to see what'll work and what won't work, what's safe and all that. But the bottom line is we don't have eradication studies for almost anything, right? Except our clinical experience. So think about this now. We're giving people 200 milligrams a week, but the best studies we have, some of the highest level studies that we have, are showing we might only need half of that, 100 milligrams a week. And in my clinical practice, we use 100 milligrams a week, 200 milligrams a week, and occasionally there are patients who are 80, 85% better, but they're not fully clear. But the Tafenoquine made the big difference. We may bump them to 300 milligrams for a period of time, but a limited period, that can be reasonable. This is targeted escalation. It's thoughtful escalation. And this is very different from what I've been hearing about 400, 500, 600 milligrams a week as a routine strategy. I mean, if you think think about it, 600 milligrams is the loading dose, 200 milligrams a day for 3 days for acute malaria protocols. I mean, to just give somebody the loading dose every single week, I mean, frankly, it's asinine. You know, this strategy, this approach was designed to get in an acute model, they're trying to get the level up quickly to kill off these infections so that we could minimize the side effects of the acute infection and also prevent chronic malaria or chronic babesiosis. This approach was not designed as a chronic weekly maintenance strategy for these complex, oxidatively fragile patients that we're all seeing. Yet, I'm hearing this being discussed all the time, relatively casually. And you know, there's people out there who are just talking about it like, hey, I did this in somebody and it kind of worked. And I'm not going to tell you all the damage I did to them. I'm just going to tell you how great it was. That concerns me. Let's really ground this in real world cases. And what does proper use really look like? In my practice, we've had patients who failed multiple babesiosis treatment regimens, have been treated upside down and inside out for Lyme, Bartonella, Strep, Mycoplasma, even mold and MCAS, and they're still sick. But everybody's chasing the Lyme and the Babesia because the symptoms look like that. Also, we have had people that we've worked on their gut. We've gotten, like I said, the mold out of the way. We've opened up the detoxification pathways. We've stabilized the mast cells. They've done all the amygdala retraining and the limbic this and that and all the vagus that and crap. And in the end, guess what? They still got persistent air hunger. They've got fatigue, right? They've got dysautonomia, brain fog, bone pain. Yet these are all things that people think of as common babesiosis symptoms. However, I've also seen those people where we just keep treating the Lyme and the Bartonella, quote unquote, because this is what we're supposed to do. They look like Lyme, they look like Bartonella. But if you look at the medical literature, if you have Lyme and Babesia together, the symptoms don't look like Lyme and Babesia together or separately. They look like those and a whole bunch more. And it's really hard to find what the pathogen is. Oftentimes, even if we inject a mouse with Babesia and Lyme, we can only find one or the other. And usually it's the Lyme and not the Babesia. So this gets missed so often, right? So when we've introduced Tafenoquine into our practice and we check that the person is G6PD competent, we get baseline CBCs and CMPs. We monitor their methemoglobin level. We dose them properly, and we do not recklessly just load them up or just keep giving them a loading dose every week. What we find is that the response can be very dramatic. Within sometimes 2 to 4 months, we'll see all kinds of things shift very predictively and positively. We see people where their Bartonella symptoms go away. In fact, just last week, someone asked me like, hey, I'm on the Tafenoquine with some other medications and some botanicals, but my Babesia was positive and now it's negative, and it's been negative for a long time. But my Bartonella symptoms are getting better, right? So I'm kind of sick and tired of everybody telling me what their Bartonella symptoms are or their Lyme symptoms, because number one, they don't know. Number two, if you think you really got the pattern dialed in, you're probably fooling yourself. We can get really close, but the bottom line is when you get co-infected, AKA you have life happen to you, all bets are off. It's not like the way we thought about it. So start knowing the patterns, but then realize that sometimes we have to do pattern recognition, we have to do labs, we have to talk to our patients. God forbid we do something like that, right? But these people are like, hey, my Bartonella symptoms. I'm like, stop telling me who made your symptoms. Just tell me what they are, and they're employing me to take care of them. This is so important for you to understand, because I've seen people with anemia, it resolves. I've seen people with Bartonella symptoms and Lyme symptoms. They all start to resolve when we take the thorn out of their side. Sometimes we're going to see those consistent babesiosis die-off symptoms, but other times we're just going to see flares and then followed by improvement of these other symptoms. So it's really important, right? And we see tons of people. I've presented cases after case after case in the last several years at conferences of like people who had been stuck, no progress for years of stagnation. We give them Tafenoquine dosed properly, and in our chronic people, it's typically low, and they're getting better finally. But it's not because we pushed harder, it's because we used the right drug at the right time in the right patient. That's the lesson. Tafenoquine is not a hammer, it's a precision tool. So With appropriate dosing, what do we expect, right? Because if anyone's taken a moment and looked up this medicine, there are some changes that are going to happen in your blood work that you must monitor for, and you must allow your patient to know ahead of time. It's called informed consent, right? Hemoglobin is going to drop 1 gram to 1.5 grams per deciliter in a normal person who's having a normal experience with this medicine. If you crank up the dose, you're going to make them super anemic. The MCV is going to rise, sometimes up to 5 or 7 points. So as they get a little more anemic, their MCV goes up a little bit. This is pretty normal to have some macrocytosis with this medication. And they will likely develop mild methemoglobinemia. This is the expected physiology when we're using Tafenoquine. And in the long-term safety data with healthy individuals given this medication weekly for over a year, this stabilizes over time with the standard dosing. That doesn't mean we just throw out our labs because we know in the safety study, almost everybody, pretty much all of them, got better without doing anything. We still monitor a CBC, CMP, and a methemoglobin level. And it's really not optional. It's really mandatory. So one of the things I suggest is that if you're going to do a loading dose, whether it's 100 3 days in a row or 200 3 days in a row, then you go a week out and you do your next weekly dose, because after that 3-day load, we just go to weekly dosing because of that really long half-life. Then 2 or 3 days after the 4th dose is when you should really get your first set of labs. If you want to do it sooner, you can, but you're going to see anemia and methemoglobinemia. You get a better understanding of where they're going to be at long term and how they're going to tolerate the medicine if you wait a couple days after that 4th dose. Now, clinically, if you need to, do it sooner. But now, if you don't load them and you just start with once a week dosing, which is very commonly one of the best strategies for chronic patients, then you maybe 2 or 3 days after the 2nd dose do it. And then maybe every 2 to 4 weeks monitor the CBC, CMP, and methemoglobin level unless you need to do a little bit more, like based on their clinical response. This is how we use Tafenoquine with structured monitoring. If you're not doing it that way, to be honest, you're just not using this medication responsibly. Here's the part that really matters. If Tafenoquine becomes associated with high dose toxicity, unmonitored anemia, severe methemoglobinemia, psychiatric events, liver injury, other mitochondrial or oxidative damage, because clinicians are just going, hey, 400 to 600 milligrams a week without any data, without any studies, without looking at how the med works, we're going to experience increased risk of regulatory scrutiny, increased risk of pharmacy hesitation, which we already have enough of that in the moment. Insurers may restrict access to the medicine as if they're not already doing it enough, right? But it could get worse. And we could risk losing a therapy for so many patients who truly need it. And this isn't hypothetical, right? This is how access disappears. And we've seen this happen with so many other therapies. And when powerful tools get abused, then they get restricted. And the problem for me is that I care about my patients and them getting better. And if they lose access to this amazing medication when used properly, then how are they going to get better? Right? We can't allow this to happen. I'm a big believer in the burden of proof. If you're someone who claims 4 to 5 to 600 milligrams of Tafenoquine per week is routinely needed, then it's on you to carry the burden of proof. So show us the controlled safety data. Monitor all your patients and publish all the case reports. We have many people in our field, like Dr. Richard Horowitz, who does this in his office. And then show us the longitudinal monitoring of outcomes, right? Double dose dapsone, quadruple dose dapsone. People were saying like, oh, that's insane. Well, it may sound like it is, but he wrote papers on it. And then we can have a peer-reviewed discussion. Irregardless of what you believe about dapsone, Dr. Horowitz has published his data, and it's out there for everyone to evaluate and determine whether or not it's valid or not. So if you're a trendsetter, if you're someone who's pushing the envelope because your patients seem to need it, and you're doing this so outside of the box, then maybe you should actually do a study and show it. Compare dosing data. Don't just go, everybody needs 500 or 600 milligrams. Hey, why don't you just compare somebody 100 milligrams a week to 600 milligrams a week? But send your labs off to multiple different labs, get it evaluated, incorporate other third parties into it who can evaluate your data. Don't just tell us to do it because we trust you, right? In the absence of any new data here, Hey, pharmacology is winning this argument. It's got linear pharmacokinetics. The more you give, the more they're going to have in them. There's a level at which anything that's, healthy at some point is going to get to such a high dose, including water, that you're not going to actually be able to handle it. You're going to get sick. Oxygen. You don't need 100% oxygen all the time. We all know this, right? Otherwise, the air would be that way. It's 21%, guys. Like, come on. You need it sometimes for a short period of time, but not forever. They've studied oxygen. They've studied water. Why don't you actually study the tafenoquine? And it's got a super long half-life. It accumulates in tissues. And there's dose-dependent oxidative stress. While that's kind of good for killing things, we don't want to make this chemotherapy where we're trying to kill the thing we're going after, presumably babesiosis. That's a whole nother argument. But the problem is we do this and it's like, are we going to kill the Babesia or are we going to kill the patient first? Let's not do that. This is not about conservatism. This is literacy. In the bigger picture, this is about maturity. Integrative infection medicine will only move forward if we can demonstrate that we have a mechanistic understanding, we have monitoring discipline, we have dosing restraint, and we have intellectual humility. I'm not saying we should never do these things. I'm just saying it's not normal to need to do it all the time. And if we think it is, let's study it and figure it out. We're not going to get credibility by being overly aggressive. We get credibility from being the most precise. So here's a grounded position, right? Tafenoquine is a powerful tool when used correctly. 100 to 200 milligrams a week is pharmacologically rational with the best evidence we have today. If you got other evidence in the future, awesome. 300 milligrams a week short-term may be appropriate in select cases. 400 to 600 milligrams weekly is rarely justified. In my use of this since probably 2019 or so, I have done that exactly once for about 2 months in a very specific patient who had extremely close monitoring every week, and he was getting better. And then it was discontinued. But of all the other people I've used this in, and I use a whole slew of this in the right people, we have not needed to go there. In fact, I think I will go on record as saying, until proven otherwise, if you need to go to 400, 500, or 600 milligrams routinely with your tafenoquine dosing, guess what? You're probably missing the mark, and there's something else going on that you should tackle concurrently or even first. So again, 400 to 600 milligrams a week is rarely justified. Monitoring is mandatory, and indiscriminate use and claims that you can't substantiate threatens access to this important medicine for our patients. We protect our patients by protecting this tool. So if you're using tafenoquine, I implore you, understand its half-life, understand linear pharmacokinetics, monitor regularly, dose intentionally. And if someone's telling you that you routinely need to use a high-dose protocol, ask them for the data, because this medicine has helped some of the sickest patients that I've ever seen turn the corner. Let's not ruin it with sloppy use. So the big picture is really this. Patients deserve our very best problem-solving and our best and often brutal honesty. For clinicians, if you're seeing striking findings, whether it's Babesia response pattern, unexpected drug tolerance, or even other parasite-like observations, document them, collaborate, submit your specimens, collect more data, and then publish it for peer review. This is how the field advances instead of being dismissed. And for patients, ask not only what your practitioner recommends, but how sure they are of that, and what is the evidence that supports it. Now, I'm not saying break their balls about this. What I'm saying is, if it sounds crazy, it probably is. And if the only place you can find any reference to needing such high doses of something like tafenoquine is a random Facebook group, I think you might want to go talk to a provider who's done some really high-level training, right? So when you're talking to your doctor, confidence without evidence, that's just noise. Confidence grounded in pharmacology data and clinical experience, that's medicine. medicine is about combining the best science with the art of medicine as well. And now that you know how to approach Tafenoquine and Babesia treatment with scientific integrity, really the next step is applying the same discipline to other controversial topics in integrative medicine. Practitioners out there, that's exactly why I created the Lyme Disease Practitioner Certification and Mentorship Program, so that we can have an open discussion of all of this, where you get that data, where you get the clinical experience from myself and so many other amazing clinicians, and then you get to share your opinion, and together we have a peer-to-peer discussion. We look at the data, we look at the evidence, and we look at our experience, and we combine that into one picture, right? And that way, when your patient comes to you and says, hey, doc, I see that you have an LDPC tag on your website, I know that you've done the work. And what you're telling me is clinically valid, and you have that highest level of integrity in what you do. How awesome is that going to feel, right? So anyway, I'm really excited about this topic. As you can tell, this is one of the ones that really has been a game changer for my patients and all the patients of the clinicians that I train. So I want to say thank you for joining me for this one, and join me next time as I dive into another taboo topic. Hey, no holds barred here, because it's all about our patients getting better and all of us preserving the integrity of functional medicine, moving it forward. Because throughout my career, all the things that my mentors have said, the science has eventually caught up to it, because they applied their clinical acumen. So let's do that together. Drop me a comment. Let me know, hey, did I get this right? Did I get it wrong? Is there something I missed out on? And also, what other topics would you like us to talk about? And if you value these nuanced, evidence-informed conversations like this one and all the others we've had here, please hit like and subscribe, turn on those bell notifications so that you won't miss what's coming next. You know, this field matures when we're willing to have these hard conversations. So let's keep having them. And until then, lots of love. See you soon.